Hello, my name is Chase Watson, and I am a SRNA here at UAMS, and I'm here to talk to you about the laws of CRNA practice and to urge Asa Hutchinson to sign Act 449, federally opting out of physician supervision requirements for nurse anesthetists. Anesthesia is neither the practice of medicine or nursing, but nurses have been in the practice of anesthesia since the Civil War, and we actually kind of started to perfect it in the 1900s, and then medicine started to kind of enter back in. We have been practicing in all different settings, and we make up 80% of anesthetists in rural areas. Currently in Arkansas, CRNAs practice under what is called physician supervision, where there is a physician anesthesiologist to 4 CRNAs, and that one physician anesthesiologist is overseeing 4 different cases simultaneously throughout the day. In 2001, CMS changed the federal supervision rule for nurse anesthesiologists to allow the state governors to choose to opt out of facility reimbursement requirements, so the TEFRA requirements. Currently, 42 out of the 50 states, excluding the territories, have opted out, but some states have not officially sent the letter to CMS. Opting out is allowing each state to give the facility the right to say, hey, we're not going to be using a physician supervision model, and so we're going to opt out of TEFRA requirements. And so that gives the hospital the advantage or the opportunity to choose what anesthesia model they want. So these are the TEFRA requirements that all the MDAs must meet when they're doing the physician supervision requirements. Basically, it's just keeping that there's a physician in the plan there for a reason in case anything happens, or that a physician developed a plan for this anesthesia case. And CRNAs can execute this just as well. I want to touch on why TEFRA is even included. So it was included in the 1980s and 1970s, where physician anesthesiologists weren't even there for the anesthetic case that they are saying that they're providing. So they were committing fraud that they were providing anesthetic care for a patient and billing, but they weren't actually present in the facility. The CRNAs were taking care of the patient. So in 2021, House Bill 1198 was submitted and passed, the House and the Senate, and became Act 449, where it changed the wording of physician supervision requirement to in collaboration with, which is essentially the opt-out legal terms for CMS. And this is yet to be signed by Governor Hutchinson. So this part is part of what the opposing side will tell you, that nurse anesthesiologists are not safe, they have poor outcomes, and that they're not educated enough to take care of these patients independently. They'll even do a little fear factor tactic to surgeons, so the surgeons won't work with them, saying that the surgeon will be liable for any anesthetic complications that might arise during the case, which just isn't true. The captain of the ship model that was previously used in the OR is falling out of practice. Surgeons don't want to be held for liable of actions of another service, and they shouldn't be, because they're not practicing anesthesia. They're doing their surgery. Vice versa, I'm not doing the surgery as a nurse anesthesiologist, so I don't want to be held liable for any accidents surgery-wise. The American Association of Anesthesiologists tried to smear the name of CRNAs, saying that they're not safe to work, they can't be by themselves, but we can watch over them and they can provide the care for the anesthetic. And they've actually published many false studies showing that the anesthesiologist is better than the CRNA. And in order to cause fear-mongering among the politicians and the public, that if a nurse is taking care of me of my surgery, that I might pass away or have a very bad complication that the nurse can't handle. It's a terrible tactic, and it's smearing in a political way. To counter the argument that nurse anesthesiologists are not prepared enough education-wise, we'll have a doctorate in nursing practice and anesthesia. We collectively have close to 7 to 9 years of college education, not to mention the 2 years of ICU experience we had to get prior to getting into a program, and that is close to 9 to 10 hours of education and clinical experience. When it comes to education comparison, physician anesthesiologists, they have close to 11 years of education, including the residency, and we have 9 to 11 years, depending on how our routes are. The hours that are used in clinical experience, we count ours whenever the patient is in the OR. Physicians count it from door to door, so it's skewed and you can't compare. So when COVID hit the world in 2020, CMS suspended supervision requirements for CRNAs, and so we were able to take care of patients because we wanted to cut down how many people were in the room. 2021, CMS reported that we were the in the top 20 most beneficial non-telehealth healthcare worker to help with the COVID shutdown. Currently in the military, CRNAs are able to practice independently with the Air Force, Navy, Army, and they're the sole anesthesia providers at all the locations around the world. But yet, when they come back to the private sector, they have to practice with unnecessary supervision and regulations despite having the practice of an independent war zone. So another positive to nurses are opting out is the reduction of healthcare cost or anesthetic cost, because you're avoiding duplication of services and you're reducing the cost of anesthesia. According to a study in Nurse Economics, the CRNA acting as the sole anesthesia provider is the most cost-effective model for anesthesia delivery. As a result of federally opting out of the physician supervision requirements, expanded anesthesia services can occur at critical access hospitals in rural areas. It'll be an accurate portrayal of the nurse anesthesiologist role, and it creates more avenues for nurse anesthesiologists to practice in multiple care settings. And this will benefit Arkansans in a very positive way, where those that live in rural areas will have access to surgical services at the critical access hospitals, whereas the critical access hospitals don't want to pay for the MDA because it's too costly for the facility. So I urge Governor Hutchinson to sign Act 449 and to opt out of CMS reimbursement requirement. It would be good for Arkansans, nurse anesthesiologists, and can function as a recruitment tool for future nurse anesthesiologists to work in our state.